name is Dr. Olivia Moses, and welcome to Wellness Live. We are so excited that you've joined us today. This session is brought to you by the Living Whole Wellness Program here at Loma Linda University Health. Today, we're going to be having a wonderful, wonderful guest speaker in February, which is National Heart Health Month. And our speaker for today is Dr. Anthony Hilliard, and he is an associate professor for the School of Medicine, and he is also the director of our cath lab here at the organization. He has been with the organization for 7 years, and he has some wonderful things to share with you on how you can stay healthy, and really, we are getting to the heart of what's important. Dr. Anthony Hilliard.
Thank you very much. It's great to be here this evening. I want to take a moment to tell you a bit about Women's Heart Month. I'm going to take you back to 1814. And you might ask yourself, what happened in 1814? Well, it's actually the War of 1812. This red dress is a red dress worn by one of the most influential first ladies of the United States. And that was Dolly Madison. In 1814, General Robert Ross of the British Army and his 4,000 troops were surrounding Washington, D.C. They were about to burn down the city, and they were coming up on the White House. Dolly Madison stood her ground defiantly. She told her staff, "We are not leaving until I have 3 things. The first is the portrait of George Washington. The second was her china. And the third were her crimson velvet curtains." You see, 5 years prior, the White House had undergone a redesign. And she was a Quaker, one who had very minimal means. And she had always wanted crimson velvet curtains. And she said, "The British can burn down the White House, but they're not going to take my curtains." So for the remainder of her life, at any important event, Dolly Madison was there, and she was wearing this red dress. And to me, that speaks of defiance. That speaks to the fact that, yes, I might have heart disease, but heart disease will not own me. And so when you think of February, think of Women's Heart Month. Think of the red pin that you see people wearing. Wear your red pin if you have one. Wear it proudly. But think of Dolly Madison in her red dress and how you approach heart disease. So for the remainder of the evening, I'm going to talk a little bit about heart disease. Why? Well, it's a fatal attraction for me. My family is a long lineage of having heart disease, and I think that's what attracted me to the profession. I want to take you back to why is the heart important? Well, the heart is a muscle, and unlike other muscles that you have, your biceps or your triceps, where you do 10 reps or 15 reps and then you stop because your muscle's fatigued, it's not surprising that your heart has to function 24 hours a day, 7 days a week, and in any condition in which it may find itself. And in fact, during this talk, depending on how much I talk, your heart will beat about 2,200 times. During the year, about 100, during each day, it's going to beat about 100,000 times, almost 40 million times per year, and depending on how long you live, up to 3 billion times. Thus, it goes without saying that we need to keep this heart muscle important, and we're going to talk about that. We're going to talk about how we keep it healthy. But I want you to think, how much does this heart beat every day? We said the number of beats, but in volume, how much does it beat? Well, think of your jacuzzi if you have one at home or at your apartment complex. It beats a jacuzzi every day, about 1,900 gallons. Now, importantly, this muscle has its own blood supply. We think about the heart ejecting blood to your legs, to your brain, to your stomach for digestion. But importantly, it pumps a lot of that blood to itself because, as we talked about, this is a muscle that has to beat continuously. So it goes without saying then that it's important to keep this muscle healthy. And the way you keep this muscle healthy is by keeping the arteries which feed the muscle healthy as well. and that is the prevention of coronary artery disease. So today we're going to talk about what happens when this doesn't happen. What can we do when that doesn't happen? Why might it happen? And how to try and prevent it from happening, because that's the most important thing. So the first myth that I want to talk about today is that most women in America will die from cancer. That's indeed false. In fact, nearly 5 times as many women will die from heart disease than they'll die from breast cancer. Think about that. Heart disease is much more likely to take a friend's life, a family member's life, or your own life than breast cancer. So if we look at it for both men and women, here shown in the tall white bar and the tall red bar, total disease deaths from cardiovascular disease. The numbers aren't important as much as the fact that it's off the chart. You take all cancers combined, and it falls well beneath what heart disease causes. If you look at accidents and diabetes and Alzheimer's, which are all very important disease and health prevention topics, they fail to even come close to the magnitude of what can happen with heart disease. I want to tell you a case. This is a case that could be anyone you know, could even be yourself. A 56-year-old female. She was relatively healthy. She didn't see doctors. She had no known medical history. After eating dinner, she was reclining in her chair, reading the paper, and she developed nausea and heaviness in the chest. She took some Tums, went to sleep, woke up the next morning, still having these symptoms. And she said, you know, they just weren't going away, and I thought something might be wrong. So I called my daughter, and she was brought to our emergency room. She did say she had this sense of impending doom, just wasn't sure what was going on, but she knew something wasn't right. Well, we're not going to go into a course on EKGs, but this is what we call a tombstone EKG. It's the setting of someone having an acute heart attack. And in the world of interventional cardiology, which is my passion, what I love to do every day of the week, we drop everything that we're doing, whether it's Christmas Eve, whether it's a birthday party, whether it's 2 a.m., it doesn't matter. Time is of the essence, and we come into the cath lab right away. This is a cath lab setup. Here's our table. Here's some of the equipment in which we use. And we do a procedure called an angiogram. An angiogram can be done either from the radial artery, which is the artery in the wrist, or the major artery in the leg, called the femoral artery. In this situation, it was done from the radial artery. This case I'm showing you was from the femoral artery. Here you can see that this should be the letter C. It's clearly not the letter C, it's a stump. Where her EKG was abnormal was suggestive of it being a right coronary artery blockage, and this is indeed what the patient had. This is the artery that we would see normally, and down here at the bottom of about 6 o'clock, this is a cartoon, you'll see a raised edge here, and that's consistent with a vulnerable plaque. That's where this plaque would rupture. So in this situation, we actually take a clot-sucking device and suck out some of the blood clot. This is what we would suck out of the artery, what's clogged that artery. That's the French fries and the unhealthy food that you've eaten through the years, all builds up into this. After we suck out the artery of this clot, you can then see we've restored the blood flow to the heart. The patient immediately feels better in that scenario. So the question you should be asking yourself now is, how does this progression occur? From a little plaque to a plaque rupture to my artery clogging up and me feeling terrible? And the answer is it actually happens in just a couple minutes, and that's the scary part. And the reason for that is there's this concept of the vulnerable plaque. For some reason, that plaque ruptures. What we've done now in the House of Cardiology is we've actually put it into a bigger picture, and that's called the vulnerable patient, the person. And there's 3 things that make up the vulnerable patient, and we're going to talk about some of those in the remaining time here today. There's the vulnerable plaque, that plaque ruptured. There's the vulnerable blood. What's your cholesterol? What's your inflammatory markers? And then there's the vulnerable heart muscle. For some reason, one heart to a different heart is more susceptible, and that's DNA. And at this point, we can't modify DNA. So when we think about the vulnerable plaque and the vulnerable patient, 30 years ago, it was this: Chesterfields, the Virginia Slims, it was cigarettes. Well, healthcare preventive measures, taxation, school-wide campaigns, etc., have done a good job in decreasing the incidence of cigarette smoke. We won't get into vapes and so forth tonight, but that's a separate issue altogether. But suffice to say, the biggest problem is no longer cigarettes. The biggest problem now is overweight and obesity. I'm going to show you this figure here. You see these two blue lines. One of these blue lines is high blood pressure. The other blue line is high cholesterol. It doesn't matter which one it is, but suffice to say, in the 70s and in the 80s, it was up here. And over time now, this is an older slide, and the data still is consistent today. When we get into the 2000s, you see clearly there's less incidence of these two things. People have done a good job taking care of their cholesterol and their high blood pressure. They still exist, but not to the degree that they did 20, 30 years ago. But the problem is heart disease is still increasing. Why is that? Well, if you look, it's directly related to overweight and obesity. This is an epidemic of historic proportions. We've steadily increased as a society in our obesity levels compared to our blood pressure and high cholesterol levels. So for this, I say, couch potatoes arise. And I'm going to show some data to support this. This isn't just a trite saying, this is the real deal. The prevalence of obesity is widespread. Back in the 90s, the green represents only 10 to 15% of the population of a given state being obese. The orange or yellow in this situation was about 20%. And the orange is greater than 25%. Well, in the 90s, most of the states were some shade of green. There was a few states that were yellow, a light shade of yellow. In the 2000s, there's not a single green state left. And in fact, there's very few of the light yellow. Most of the states are characterized now in a sense that wasn't even characterizable back just 10 years prior. So the obesity epidemic is widespread, and it's the real deal. The U.S. is already the most obese state in the nation, and we're getting bigger, and it starts in adolescence and childhood. It's not because we're eating more calories. And in fact, if you can see, the calorie intake is steady state. It's not changing. You may ask them, why are we getting fatter? It's a great question to ask. It's the type of food that we're eating. We've gone to a simple and complex carbohydrate diet that is often low in substantive foods, fats and proteins. These are good foods that maintain satiety and not increase our desire to want more. And so it's the change in the type of food that we've eaten, not the calorie content, that has led to the obesity epidemic.
Okay, thank you, Dr. Hilliard. It is time for you to ask your questions, so go ahead and type your questions in, and we will ask Dr. Hilliard your questions live. We have a few that have come up already, and what we're going to ask you, Dr. Hilliard, one of the questions is, are the symptoms for cardiovascular disease different in women versus men?
It's a great question. So in our own database, we have a team called a STEMI consortium, and we collect 84 variables on every single person that comes to our ER with a heart attack. What we've appreciated is the following. The majority of women who come in with a heart attack have chest pain, very similar to a man. So chest pain is still the most common presenting symptom. That being said, there are more women who have other symptoms than chest pain. The case example I showed, her predominant symptom was GI. And most people with GI symptom, they say, well, maybe I ate something bad, I'd take a Tums or something like that. So the vast majority of people still have chest discomfort in some description, but women do have more other associated symptoms.
Okay. So a follow-up question to that is, so if they have these other symptoms and you don't want to look like you're, always panicking and going to the ER, when is the right time to go to the ER?
So the one thing I always, I don't want to say scold anyone, but I do.
Okay.
If you have chest discomfort, no one's ever going to fault you for crying wolf. Number one. Number two is, generally speaking, that puts you near the front of the line. So people will say, well, I don't want to go to the ER. I'm going to have to wait several hours before being seen because they've happened with an ankle or something like that. You have symptoms that are concerning for a heart attack, and you present that symptom presentation to the ER, you get to go to the front of the line. So in my opinion, if there's any sense of concern on the individual, go get checked out. Okay. Now that being said, people who are having a heart attack often describe this sense of impending doom. Doc, I don't know what's going on, but something's not right. And so the problem is people often have that sense several hours into their heart attack, and they weren't that impressed by their symptoms early on. So if you've never had something before, and now you're having something, and it doesn't just sit quite right with you, go get checked out.
Okay, so better safe than sorry.
Absolutely.
Okay.
We can't undo a heart attack.
Right.
So if you say, son of a gun, I did have a heart attack. Well, time is of the essence. And so if you have any questions, concerns, I always actually mandate that you got to go get checked out. There's no time to mess around.
Okay. So another question that we have here is they've heard a lot about inflammation. What role does inflammation have to play with CVD?
So this is a great segue for a slide moving forward. It's very controversial. We do know the following. Inflammation plays a role in the development of coronary artery disease. Whether that be systemic inflammatory conditions like lupus or rheumatoid arthritis, things like that, whether it be more localized within the vasculature, what we call the endothelium, which is the biggest organ in the body, I think the verdict's still out on that. That being said, there's no question that inflammatory conditions heighten your risk for coronary artery disease. Not only that, plaque formation is a result of oxidization, and that's a direct result of inflammation. So at the fundamental level, the development of plaque or coronary artery disease or cerebral vascular disease or peripheral vascular disease is at the most basic level, oxidization, which is an inflammatory condition.
Okay. Oh, please.
And in a few minutes, I'll tell you what you can do to try to reduce your inflammation.
Okay, we can't wait. One more question. So what we have here is, let's say, here we go. I struggle from anxiety. And how can I tell the difference?
So, people who have an anxiety condition that they may have had since age 18, age 24, age 30, is going to be pretty consistent. They're going to know, when I talk to people, now this isn't my opinion, this is just when I interview people, patients through the years. Patients know their anxiety. When they have their heart attack, because people with anxiety disorders can have heart attacks, it's usually very different.
Okay.
So if it's, I have panic disorder and, I'm in my usual element and I feel that symptom, it's probably not your heart attack. But if you say, you know what, I'm at home with my family, I don't usually have my panic disorders now. Or you know what, usually, yeah, I'm anxious and I had this, but this is completely different than any panic attack I've ever had. Those two things in my mind, an environment in which you don't usually have your panic attack, or a completely different set of symptoms, those are cause for concern.
Okay, great. So I just want to remind you, now's the time to type in your questions while Dr. Hilliard is going to be talking about his second half of his presentation, and we will be back with you in a few minutes.
Thank you. So these were great questions, and they lead in very nicely to what we're going to talk about in the next several minutes. So you got to know your numbers. You know your ATM number. You know your phone number. You know your email address. You got to know these numbers. These numbers are equally or more important. You got to know what your cholesterol is. You got to know what your bad cholesterol is, because there's a difference. That's your LDL. The way to remember it, you can impress your doctor, is the L's. So LDL is lousy, so you want it low. You got to know your good cholesterol, HDL. HDL, H, you want high because it's heavenly. So you want high HDL, low DL. You need to know these. You want your LDL as low as possible, ideally under 70. That being said, every trial that's ever been done on the face of the earth, the lower the LDL, the better you are. Your HDL. HDL, the higher it is, the better you are at every level. Triglycerides, those are the circulating fats. You want under 150 for sure. Inflammation. CRP is a very basic, every lab can order a CRP. That is a measure of systemic inflammation. If your inflammatory markers are high, but your cholesterol is low, you still may be a candidate for medication to treat your CRP or your inflammation. And that's important. So just because your cholesterol is good does not completely get you off the hook. We're going to go to the stuff that's not so fun to talk about. You need to know your blood pressure. I ask people under 40 all the time, what was your last blood pressure? And if they don't have a history of hypertension, 95% of people have no clue what their blood pressure was. The problem with that is blood pressure, hypertension is a silent killer. You don't feel bad, it just stays high for a long time. So anytime you have an opportunity at a local drugstore, it's free, go get your blood pressure checked. You need to know your waist. How many of us have put a tape measure around our waist at our navel? You got to know it. Men get 37, women get 35, but I don't pass men. I don't give men a pass. They need to be 35. There's no greater predictor of badness than waist level, than waist circumference. The visceral fat in the tummy is an active inflammatory beast. It creates and circulates all these evil hormones that do a lot of things to the body, one of which is impacts negatively the development of coronary artery disease. Inflammation. Think of the tummy fat as this inflammation circulatory pool donor. It just is there feeding that, and it needs to be controlled. Fasting sugar. When was the last time you had your finger pricked? You need to know what your fasting sugars are. Should be at least less than 100 and should be into the 80s without question. How to prevent a heart attack? Well, portion control. Portion control. Don't go for the quadruple stack pancakes. If you have a hard time knowing, well, what the heck's a cup? I have no clue what a cup is. Draw your plate like this. On this side, between 6 and 12, should be fruits and vegetables. Should be over half. Between 12 and 3 should be proteins, lean proteins. Down here, between 3 and 6 are grains, whole grains, good food for the soul. In addition to that, you need some calcium-based food. People always say, well, how do I prevent a heart attack? And I like to quote Yogi Berra, the famous, recently passed catcher for the New York Yankees. Prediction is difficult, especially about the future. We don't know, but we can only do what we can do, but there's a lot we can do. So these are foods. This is Dr. Hilliard's foods to prevent a heart attack. Just my opinion, based on some data though. Eat your oats. When you go to the cafeteria, get the oatmeal. Get the oatmeal. They have this thing called beta-glucan. It's this cholesterol-busting soluble fiber. It goes in there and just sucks up all that cholesterol. Eat your nuts. There are good nuts. Remember WAPP, W-A-P-P, walnuts, almonds, pistachios, and peanuts. They actually have a natural cholesterol fighting medication, we would call it, a sterol. It absorbs the cholesterol. Eat your lentils, your legumes, but specifically lentils. If you looked at a 21,000 person international study, there was actually an 82% decreased risk of death from heart disease if you ate your lentils. Have bad breath. Eat your garlic. It slows plaque progression, and it's an artery dilator. We like dilated arteries. This is easy in Redlands, which was once the orange tree capital of the world back in the 70s. Eat your oranges. They're salve for the heart. The fiber pectin, the soluble fiber pectin, acts like a giant sponge and just soaks up that cholesterol. And then for good measure, eat your dark chocolate. This is the bad tasting dark chocolate. It has very high flavanol content, and it's in the unprocessed chocolate. You want it to have 30%. It shouldn't be sweet. Because any sweet chocolate's been processed. And when it's processed, you can actually harm the actual fighting heart disease properties. Exercise. So if you look, over time, if you're age 18 and older and you're of any race, compared to the 80s, when you compare it to the 90s, and you compare it to the 2000s, we do good at exercising our 20 minutes a day, but the rest of the day, you know what we do? We sit, and we do this with our scroll pad. We have very little leisure time physical activity. We don't move around. So get up and move. That's very important. Why? Because you're 3 times less likely to die of a cardiac arrest. 3 times less likely to die of a cardiac arrest if you have moderate to high intensity physical activity. We need you to move around, not just when you're supposed to move, but you're supposed to move all day long. Lace them up. Lace up those sneakers. If you do just one thing, move 30 minutes a day. And we have all sorts of devices to tell us how we're moving. And that's important because a half an hour of moderate intensity activity will lower blood pressure, will decrease your circulating fats, will raise that heart-healthy, high, heavenly HDL cholesterol, and it will cool the inflammation. Does that largely by decreasing the waist size. And your heart doesn't care if you do it 30 minutes at a time or 10 minutes, 10 minutes, 10 minutes. I hear people say, I don't have 30 minutes to give. Yes, you do. It's in your day. Make it a priority. It's important to incorporate strength training into that program a couple days a week for 2 reasons. One, you pay it forward as you continue to age. Having more muscle mass will decrease your risk of fall, etc. But importantly, if you have more muscle, you have a bigger furnace. So that means when you are sitting around, you're burning calories at a higher rate than that person who has very little muscle. So build that muscle. It's good for multiple reasons. And remember this picture. Why? Because kids forget 70% of what you say, and they remember 90% of what you do. So if you tell your kids to eat your vegetables, but you're not eating your vegetables, you know what they're going to do? They're not going to eat their vegetables. If you tell your child, don't watch so much TV, go outside and play, but you don't go outside and play, what are they going to do? Remember that. Kids forget 70% of what you say, and remember 90% of what you do. If there are questions that we don't have time for this evening to address, I want to hear every single one of them. This is my Loma Linda email. It's aahilliard@llu.edu.
Well, thank you so much, Dr. Hilliard. This was excellent. So we have a time for a couple questions, if you don't mind. So the first question we have here is, my husband was diagnosed with heart disease. Do we need to be concerned about him pushing himself with exercise?
So that's a hard question for me to answer without knowing the entire history. The goal for people with heart disease, however, is that they actually participate in a routine, rigorous exercise program. Not for primary prevention because the horse is already out of the barn, but for secondary prevention. So in people like I showed today who have the heart attack, we actually get them into a program called cardiac rehab. And it's a 36-session, 3-hour program paid by every insurance to help them get back into that routine. Because the first thing that's going to come to mind with anybody who's had a heart issue is, am I safe to exercise?
Right.
Doc, I'm nervous to do it because what happens if something happens? So the 36-session, 12-week program helps to make sure, number one, that the patient's safe, but number two, to build the confidence. So the expectation should be of that patient that they should be in a situation good enough where they can exercise. So I actually have all my patients exercise, there's a few exceptions to that. And I use that as my measuring stick. Doc, I ask, how you doing? Hey, Doc, I'm doing good. I'm doing my mile route every day and I'm having no problems. Or, I'm getting to that 3/4 mark and I'm just having a hard time. Or my times are slow or I'm not doing well. It actually provides me with a lot of information. So the answer is yes, they should exercise. The first thing I would say though with that is make sure you talk with your doctor that you're safe, because the expectation should be that he is.
Okay. Then, we have time for one more question, so really quickly. The question is, what is the connection between diabetes and heart disease?
The answer is yes.
Okay.
It's actually a heart disease equivalent. So when we look at risk factor modification, if someone has diabetes, we treat them from a blood pressure and triglycerides and fats component, cholesterol component, as if they have coronary artery disease. I didn't have time to show it today, but diabetics, particularly diabetics whose hemoglobin A1C is not well controlled, it's in the 7s, have an incidence of coronary artery disease that is much higher than the rest of the public. So for that reason, if you're a diabetic, we treat you as if you have coronary artery disease.
Wonderful. Well, we would like to thank our audience today. Thank you so much for joining us here for Wellness Live, and we want to thank Dr. Hilliard for joining us as well. And again, next month we have another session, so we would love to have you visit us. Thank you again, and have a great evening.